Welcome back to the podcast. In this conversation, we're going to be examining the concept and skill of front of neck access and also the suction assisted laryngoscopy and airway decontamination technique, or SALAD. So joining us to dive into the FONA procedure and indeed the SALAD procedure is pre-hospital retrieval specialist Cliff Reid. So we're going to explore the indications, complications and potential risks of front of neck access, or FONA. Cliff is going to talk us through the innovative SALAD technique, which also mitigates complications and improves success rates. So we're also going to look at some real-life case studies to illustrate the challenges and indeed the decision-making involved in pre-hospital FONA. So to do this, I have Cliff Reid with me. Cliff has over 2 decades of experience as a doctor with Sydney Hems. He's also developed extensive experience in advanced airway management techniques. So as an educator, Cliff has trained numerous pre-hospital clinicians worldwide and indeed shared his knowledge for advocating for best practice in airway management. Welcome to the podcast, Cliff.
Thanks very much.
I wonder if we could just start, Cliff, by just exploring the indications for performing front of neck access in the pre-hospital environment.
Sure. To me, you go through the front of the neck when you don't have an opportunity to go through the other 2 orifices. If you can't go through a natural orifice like the nostrils or the mouth, then you go through the neck. There's 3 routes into the airway, and it's just one of those 3 routes. Now, nasotracheal intubation isn't usually done. It's quite hard, but we can certainly use adjuncts through the nose to help keep a patent airway. But if we're in a can't oxygenate situation and we've exhausted those possibilities, then that would be one indication for making our own hole in the front of the neck. Another much rarer one, I guess, is if you've got a trapped patient and you literally can't get to the face to instrument the airway, you've only got access to the neck, then that might be an indication for a primary surgical airway or primary front of neck access. But yeah, just to keep it simple, if I can't oxygenate a patient through other means, then I make a hole in the neck.
Yeah, which makes sense, absolutely. And it is quite a rare procedure, actually. I mean, I've only done 2 in my career, but maybe could you talk us through the potential risks and complications with pre-hospital FONA?
Sure, it sounds cheesy, but the biggest risk is not doing the procedure. It's failing to make an airway when you had an opportunity to do so. Of course, it's a surgical procedure generally, so there are risks with any surgical procedure. You can cause bleeding, there can be infection downstream, you can damage airway structures, you can damage vascular structures, you can damage nervous structures. But if you stick to the midline and you stick to a simple procedure that's honed, you're probably not going to cause any permanent damage that an ENT surgeon can't repair. So while it's prudent to consider complications of any procedure, you're not really going to do a front of neck access procedure unless the patient's in a life-threatening situation if you don't do it. So those risks of benefits versus harms are so in favor of benefits. It's such a tiny consideration. If you stick to the procedure, it's not really something that should be a reason not to do it. The caveat there is in infants and small children. If you're going to do front of neck surgical access there, and there are circumstances where that's indicated, the procedure is fiddlier and you do have a greater risk of causing significant injuries to the adjacent vascular structures. But again, there's a system you can train in procedurally that will minimize those risks.
No, indeed, absolutely, absolutely. And let's just look at how to mitigate some of those risks. Could you maybe speak us through the SALAD technique, Cliff, and indeed how that does offset or indeed mitigate some of the risks?
Yeah, sure. So just for the listeners who might not be familiar with it, SALAD stands for suction assisted laryngoscopy with airway decontamination. So this is a means of doing laryngoscopy through the oral route to do orotracheal intubation. When you have a heavily contaminated airway, it might be vomit, it might be blood. And the procedure and the name were both invented by my friend James Ducanto, Jim, who's an anesthesiologist in the US. But He's also a serious resuscitationist, inventor, engineer, all-round amazing guy. And yeah, I've had the privilege to have some training from him some years ago and refreshed that recently with him this year. And the way Jim recommends you do it is you have a proper suction catheter in your right hand and the laryngoscope in your left hand. And you're anticipating a contaminated airway. And the key thing, and this is really important with video laryngoscopy, is that you don't allow your lens to get contaminated. So the suction catheter has to stay ahead of the laryngoscope camera, which is usually at the tip of the blade. And so the suction catheter goes in first. You might open the airway with your left hand, then you hold the suction catheter similar to the way you're holding a laryngoscope handle. So the curve of the catheter is the same as the laryngoscope curve. It's going to go around the tongue. But you can actually use that catheter to push the tongue down, almost like a laryngoscopy technique. You're making more space in there. You're pushing the tongue forward into the submandibular space, and you're actively suctioning the whole time with this right hand. You can then follow that with the laryngoscope in your left hand, and they use the term high and dry. Keep the laryngoscope blade high, so further out than the suction catheter tip, which keeps it dry, so your view remains pristine. It doesn't affect the video. And what you do is that you feed the suction catheter further down. This applies to contaminant coming up from the esophagus. And so you put it in the hypopharynx, the area just at the entrance to the esophagus, and you park your catheter tip there. And then there's a maneuver where the suction catheter is in your right hand, but keeping the tip where it is, you move the handle around and under the laryngoscope blade and into your left hand, so into the hand that's also holding the laryngoscope handle, and you pin that suction catheter between your palm on the little finger side, so your hypothenar eminence, and the laryngoscope. So you've coming from left to right, you've got your left hand, then you've got the suction catheter, then you've got the laryngoscope, and that suction catheter is pinned between your hand and the laryngoscope. So now you're holding two instruments with one hand, or two devices with one hand. You've got the suction catheter in your left hand, which is sitting in the place where it's going to suck up all that stuff coming up from the stomach, and you've got the laryngoscope. So now you have a clear view. Any ongoing regurgitation is going to come up your suction catheter, and you've got a free right hand for your bougie or your tube with a stylet in it, or even a second suction catheter to clear out any remaining contaminant before you intubate. And this is really tried and tested technique. It's very simple to learn. And what I love about Jim is rather than just make up a technique and get people to train it on a sterile mannequin or a dead animal, is he's invented a number of salad trainers, so mannequins that will actually actively vomit and will pump up that mucky stuff, and it will just keep coming. So thanks to him, and with the help of a German emergency medicine colleague called Luca Unlu, we made a number of salad trainers in our own department here in Sydney, adult, child, and infant. The infant one's interesting because we go to quite a few pediatric drownings, sadly, and we have a number of recorded video laryngoscopies of significant pulmonary edema coming up via these infant airways. So our infant salad mannequin doesn't vomit, it has pulmonary edema, pink frothy stuff coming up from the trachea, which is a bit of a challenge because you have to modify your salad technique. You can't park it in the hypopharynx because it's not coming from there, it's coming from the airway. So that's a very challenging intubating mannequin.
No, indeed. And just a couple of, like you said, you always have to be flexible with these areas because, as you were saying before, the disparate nature of breastblock care is the fact that most of these patients are unfasted. And in my experience, suctioning the airway in an unfasted patient, the the food coming up from the stomach or indeed from the esophagus is one of my things I had to learn quite quickly was sometimes taking the Yanker sucker off because just the detritus or indeed the food stuff coming up would block the Yanker quite quickly from the esophagus and just render suction useless. So actually sometimes having to almost pivot, take the anchor off so you can increase the diameter of the suction or just the tubing so that there's almost an improved efficiency and efficacy of that suction in the hypopharynx just to be able to still visualize the field. Is that something that you advocate or indeed practice, just kind of almost increasing the size of the bevel by taking the yanker off?
Now, I have absolutely had to do that. I completely agree. But of course, the Yankar is the commonest type of suction catheter available in hospitals and pre-hospital, but that's only for traditional reasons, and it wasn't designed as a resuscitation device. Jim has invented a device called the Ducanto catheter. I know the guy, but I have no financial interests in it. But this is what we use pre-hospital here in Sydney and in our emergency department. And so the anchor device, the way it's designed with its, if you can picture it, if the listeners can picture it, it kind of sort of bulges out into a curved tip. That's designed to actually apply direct pressure during surgery to control bleeding. So if you've got a bleeding tonsil, the Janker sucker can actually push on it while it's sucking out blood. It's not designed for Brussels sprouts and peas and lumps of potato and things. And so if you've got a Janker suction catheter in a resuscitation setting, you are often going to have to do exactly as you've just described and recommended. You've got to take the thing off and just use the piping. Otherwise, it's not going to suck up the lumps. Whereas a proper resuscitation catheter like the Ducanto will be much more purpose built, and you're less likely to have to take the thing off. It's quite wide bore.
Ah, we got cut off. There we go.
You did,
There we go. I
yeah.
don't quite. Yeah, I don't know quite what happened there, whether it's my side or your
I'm not
side.
sure.
Um, Sorry about that, Cliff. I think let's just go with that one again, actually, because I can splice
Yeah.
those two together actually. I'll just tee you up for that.
Where was I when you
Um,
got cut off? Do you know?
it was just talked about the using it within Sydney Hems, the differentiated one, the different suction catheter, and then I think I started to lose you after that. Actually, yeah. Do you want to just go again from there, just from using the American model, sorry, your friend's model, um,
Mm.
and I can splice that in. Sorry about that.
No, no problem.
And so, Cliff, just if you could just talk us through how you pivot away from, indeed, maybe the Yanker that again. So, Cliff, I just wondered if you could just talk us through pivoting from the Yanker suction catheter to maybe a larger bevel catheter, and indeed the advantages of that.
Yes, because of course many people still have the Yankar catheter in their resuscitation setup, pre-hospital or in hospital, but it was never really designed as a resus airway device. It was designed during surgical procedures with its sort of bulged round tip to place direct pressure onto surgical bleeding sites and suck up the blood. It's not designed for your Brussels sprouts or potato or peas or things that are coming up from the stomach. And that's why a dedicated resuscitation catheter like the Ducanto catheter, and I've got no financial interest in the device manufacturer, but this is what we would use here in Sydney pre-hospital and in our emergency department. And it really is just a thick plastic catheter, much larger than the Yankauer, which can suck up big stuff, but also cleverly shaped So it can be used, as I described earlier, almost like a laryngoscope blade in terms of helping to control the tongue and go around the tongue and sit in the right spot for your salad technique.
So just
But
looking, yeah, carry on, sorry, Mike.
and if you don't have that, if you've still got the traditional Yankoa, then yeah, absolutely, as you've described and recommended, it's going to have to come off sometimes, and you just use the piping to suck up the lumpy stuff. Otherwise, it's just going to block the catheter.
So, Cliff, let's just stand back for a second and look at some of the human factors. We can look at some of the sort of human factors regarding kit initially, if that's okay. And then maybe some of the larger human factors, because something you said prior to now, which is fantastic, and I fundamentally agree with, is it's it's not just the technique itself, and actually this applies to the whole of pre-hospital care. It's actually mimicking and training some of the external pressures and some of the human factors, and indeed challenges that you feel and are burdened with as a provider in situ, and trying to mimic that, because that certainly affects performance. So I'll just look at the kit initially. Could you maybe speak to how prudent it is to really reduce the number of articles in the kit, just to keep it, as you were saying before, keep it simple? And then maybe we'll stand back and look at some of the larger external human factors as to how we perform under pressure. But could you maybe speak to the kit initially?
Certainly, as you say, complexity is the enemy of execution. So it's got to be simple from a human factors point of view. There's going to be a lot going on scene. There's going to be a lot going on in our brains, and the patient's going to be really sick often, and we're not going to have a lot of time. So there are various proprietary devices out there, but the system that I'm working recommends just using simple, available kit that we're all familiar with. So a scalpel blade, a bougie, a tube, maybe some gauze to control bleeding, and then all the things you need to have when you intubate someone, like a syringe to inflate the cuff, and your self-inflating bag, circuit, and capnograph. But for us, we use a scalpel finger bougie technique. And you really want your kit packaged in a way where it's easy to check. So if it's in a transparent container, bag, pouch, whatever, then you can eyeball that kit at the beginning of your shift. You know it's all there. It can be tagged. And it's easy to retrieve when you're under pressure if it's kept in a standard place. And if you use an airway checklist, then you can make sure that checklist prior to intubation or prior to anesthesia includes that you've seen where your cricothyroidotomy or FONA kit is, and in some cases you've even got it out ready. You may have even marked the neck.
No, indeed, absolutely. So it's clear and visible, but like you said, there's an absolute reduction of kit there, so it's nice and simple. Yeah, Cliff, could you speak to the wider considerations? I think, fantastically said around, you have different trainers, a pediatric, a young person, and indeed an adult trainer, which mimics a very difficult airway, and maybe a very difficult airway to practice FONA and salad techniques on. Could you maybe speak to, because these are halo um, skills, yeah, high acuity, low occurrence skills. They do occur infrequently. So, to your career as an educator, it's so important that you almost match these high fidelity situations. So to prepare clinicians, I think, for these infrequent events, could you maybe speak to the wider scene and how we almost anesthetize, or how would I put it, just mitigate some of these factors?
In terms of how we train,
Yeah, indeed. Yeah.
as you say, it's a halo procedure. So the opportunity to see one, do one, teach one, or do it for real under supervision just isn't going to be there. So your first one you ever see is often the first one you ever do. So we have to be 100% prepared for that. That means we need to be familiar with the equipment, familiar with the procedure, how to do it, but really, really familiar and confident with the indications for the procedure, so that when those indications arise, there is no decision. We've already made the decision in the past. This works really great with teams. So in our HEMS unit, we have a physician and a critical care paramedic. And so they would confirm indications together and proceed to surgical airway or proceed to FONA. And no one's having to have a discussion or a decision. You just confirm as a team the indications are present, and that's your trigger to go. And then you want to make sure that your head's in the right place. You cut out the noise and you get yourself in the zone, and everyone's got their own way of doing that. But the nice psychological tools for dealing with stress or emotional pressure that are recommended from Mike Loria and his crew include the breathe, talk, see process. So slowing down your breathing, square breathing, combat breathing, whatever you want to call it, just slowing down your breathing, which will control the rest of your autonomic hyperarousal. Talk is your positive self-talk. So if you do have any self-doubt or you are hesitating, just to yourself, silently, in your mind, you tell yourself, I've got this. We can do this. We're trained. It's indicated. It's go time. And then C is visualization. This is the successful completion of the procedure in your mind's eye, visualizing a successful outcome. No, expecting what it's going to feel like and look like if it goes right. And again, it's better if all this stuff is done in the past so that you're ready at the time. And then once your head's in the right space, your kit's out, the team's good to go, we would make sure we position our patient with the neck extended. So we'd remove any pillows or occipital support that we had in place for intubation. Confirm landmarks, do a laryngeal handshake, grab hold of that cartilage, and with one finger feel the cricothyroid membrane, and then with the other hand we do a stab and rock incision if the membrane's palpable horizontally. Bougie goes in. Finger goes in. So a stab and rock incision horizontally if we can palpate those landmarks. We then put a finger in the hole and we confirm out loud, I can feel tracheal rings with my finger. We then pass a bougie alongside it. I can feel a bougie. So if you can feel tracheal rings and you can feel a bougie, your finger is definitely in the airway. So the finger can come out because the bougie is definitely in the airway. And then the tube goes over the bougie, the cuff's inflated, end-tidal CO2 is connected. We start bagging. We look for capnograph. We listen to the chest. And we hold on tight to that tube, that successful airway, because that needs to stay in. And then how do we train for that? We've got the psychomotor training, so the motor skills, and we've got the cognitive training as well. And throughout our induction process, we would step up the intensity of the training. So it would start on a part task trainer, just going through the process. We then do it on a pig carcass. That's how we practice a lot of our halo surgical procedures. We then do it in simulation, and then without giving too much away in our testing process, we have an exam where procedures like that have to be done in a simulated scenario with a number of other things going on that really increase the stress. So stress exposure training or stress inoculation training, so that we know that our teams are capable of doing this procedure in any circumstance. But it doesn't stop there. Again, in our system, we have airway currency training. So every 30 days or 60 days, depending on your clinical level within the service and whether you're full or part-time, we have to go through something called airway currency training, where we revise our airway procedures, including surgical airway. So we just keep it fresh. But on top of that, we expect people to keep themselves psychologically current by rehearsing and simulating in their own brains. And you could do this, while queuing up for coffee. You could you could be going through, if I have to do a surgical airway this week, how am I going to do it? Just run through those steps in your mind's eye. Next, please. So you're one step forward in the coffee queue, and then you think, right, I'll do another one. And then, you might have done 4 surgical airways in your head by the time you get your coffee in your hand. And that's really good simulation. That's powerful stuff. We've got such a good, high powerful, high fidelity simulator between our ears. It makes sense to use it to prepare for the halo procedures.
No, indeed, actually. And to your point, actually being able to lean into quite a lot of subconscious training so that you've done it in practice and or imagistically many times. So to lean into that subconscious training, really, which is some of the most profound training we have. Cliff, could you speak to the complications of surgical emphysema? Because one of the challenges I faced in the past is when a patient does a profound surgical emphysema, there's a real loss of differentiation of physiology or indeed anatomy because of profound surgical emphysema. How do you overcome that? Do you just push through that? How do you teach around that when performing FONA?
Yeah, surgical emphysema is going to be one of those anatomical factors that's going to make this a challenging surgical airway. And other ones might be, paratracheal hematoma that's distorting the anatomy and ruining your midline orientation. And they can make it extremely challenging. There's good surgical emphysema and bad surgical emphysema. So good surgical emphysema was caused by the injury. There's a laryngotracheal disruption. There's leakage of air into the soft tissues of the neck. And that's something that you're going to save the patient's life from. Bad surgical emphysema is when the patient didn't have surgical emphysema, and then you've tried to do a surgical airway and you've gone in the wrong space and you've connected the bag and you've inflated and you've got no internal CO2 because you've created a false tract. And now you're blowing up the tissues full of air. That's bad surgical emphysema. None of us ever wants to be there. So the good surgical emphysema caused by the injury, you're going to do your best for the patient. And whereas we love palpable anatomy and reassuring landmarks, and we can go straight into the cricothyroid membrane, sometimes the patient's obese, or there's hematoma, or there's a mass of some sort, or there is surgical emphysema, and then you just may need to cut down. You may need to do a vertical incision until you find the airway, and then you make the horizontal incision through the cricothyroid membrane. There's a greater danger of bleeding in that situation. But again, for larger children, teenagers, and adults, where we're going to go through the cricothyroid membrane, this is expected. We're expecting it to be a non-visual, bloody procedure in which we're using tactile senses. We're going to put our finger in the airway and we're going to confirm those tracheal rings. So we're not relying on being able to see the anatomy anyway. It's all about feel. So identifying the midline, cutting down to airway, cutting through the airway and sticking a finger in it, that's the way to go. It does get more complex in infants and small children. But we can talk about that another day if you want.
Indeed, indeed. Cliff, could we just look at really some cases from your perspective? Indeed, a challenging case which you've maybe garnered a lot of experience or indeed reflections from regarding FONA. Is there a sort of seminal case in your mind that you really learned a lot from?
There's a few. I've only done 2 in my whole career, so I've been lucky. And I think a lot of that comes down to working in systems that concentrate on first pass success. So not just the salad technique, but the positioning and the adequate dose of rocuronium and all the things you put in place, proper pre-oxygenation, proper hemodynamic resuscitation, all the things you put in place to make that laryngoscopy very likely to be successful on the first attempt. And so in our service, surgical airway is very uncommon, very uncommon. So there's, despite a couple of decades being there's only a handful of cases any of us have come across or are aware of. So that's great. There was a case right at the start of our current service where we were still writing SOPs, where a two-person procedure was taught where the assistant would be holding retractors and the physician would be performing the procedure visually. And it was a guy who smashed his face. He was on a jet ski and smashed into another jet ski, had major facial injuries with hemorrhage and a decreased conscious level. And he was anesthetized, but had an unsuccessful laryngoscopy. And he was temporarily oxygenated with a supraglottic and eye gel while they did a surgical airway. So saturations were sort of maintained in the low 80s. So they had time and they tried this procedure that was taught back then. And someone had the wherewithal to video it. And I got to see the video. And they didn't have the right tissue planes. They put the bougie paratracheally rather than in the trachea. They thought they were in the airway. They connected. They put the tube over the bougie. They connected the bag. They inflated, but they had no capnography, no chest rise. And they picked up very quickly, this is not in the right spot. And so this was a failed surgical airway, which is very rare. And this is something that can really test you psychologically. Where do you go from here? But they had the cognitive capacity to say, right, well, the way we did it's not working. Let's do it a different way. And the physician recut the cricoid membrane and put his finger in and felt those tracheal rings, bougie, tube. So essentially, he essentially for himself invented the scalpel finger bougie technique, even though he'd never heard of it at the time. He realized, he created that approach for himself because he wanted to be sure he was in the airway and it was all very bloody. And that was great. And the fact that they videoed it, the whole team could learn from their, not mistake, learn from their success. And we changed the system. We changed the way we taught it as a result of that case. So that was fantastic for that team to do that. The patient did fine and subsequently gave permission for that video to be used for training, and it's been presented at various conferences by that doctor since then.
No, indeed, and it's informative for many reasons. Like you said, a lot of learning can be garnered from that, and indeed, like you say, the SOPs can be pressure tested and changed on the back of some of these seminal cases. Cliff, could you speak to transitions of care within, so patient handover really of a FONA patient? Some of the transitions of care can be maybe sometimes the most risky, and for the patient, and indeed sort of the scene itself. Could you maybe speak to some of the nuances or indeed gems of wisdom around the ongoing care or indeed handover of a patient after pre-hospital FONA?
Yeah, sure. So maybe if we take it from the point of confirming that end-tidal CO2, the tube's in, we have to be mindful of a few things. If the patient is alive, so it's not a cardiac arrest patient, then they're just like any other intubated patient. They might need ongoing sedation, analgesia, and I would definitely, in our service, give a muscle relaxant. I don't want this tube being coughed out. This tube has to stay in. So the patient's going to be flattened with anesthesia and neuromuscular paralysis for starters. I'm not going to let go of this airway. We'll try and secure it, and we don't have a rigid recommendation about how it's secured. We've got the option of tube ties, sutures, tape, whatever keeps it in, but we're probably going to have a dedicated clinician holding it as well. Because you've gone into the airway much lower down the neck than you normally would, you normally go through the mouth, there is a danger that tube's going to go into one main bronchus. So we're going to be really vigilant about that bilateral chest rise and keeping an eye on the end-tidal CO2 and the saturation. And then at handover, what there's a risk of is that that resuscitation team is going to get fixated on this. Many, if not all, of that resus team will be seeing a front of neck airway for the first time, and it'll be fascinating to them, and they're not going to hear the rest of your handover, and they'll lose situational awareness. So on the pre-hospital alert, when we call from ambulance to hospital, we'll let them know that the patient has had a cricothyroidotomy. Just so when they do their briefing before we arrive, it's not a surprise to anyone. And then on arrival, the person is usually going to be the physician who's holding that tube, is going to keep hold of it during the handover process, the verbal handover, and also during the physical handover onto the receiving hospital stretcher or bed, so that no one else has the opportunity to pull that tube out. And then whoever your airway clinician is that you're handing over to, after the team handover, an additional airway handover to them. What we found at laryngoscopy, why we had to do a surgical airway, and what size tube, how far it's in, how we've secured it, or how we've not secured it, so they're aware that it could be pulled out, and making sure they're absolutely clear on what that is and why it's there and what their challenges might be. If this patient genuinely had an unanticipated, impossible laryngoscopy with a grade 4 view and an inability to pass a bougie, we want them to know that. We want them to know that even with our video laryngoscopy and optimal positioning and paralysis, this patient wasn't intubatable, so that they don't just assume that, oh, these guys failed because it was pre-hospital, let's just pull that out and put a proper one in up the top end, because they're going to end up in the same difficulty. So I think that a really clear handover with closed loop communication, so everyone understands what's there and why it's there, is important. And trying to make sure that the handover, the verbal handover, according to our usual structured template, is done before letting go of the patient, so they're not distracted and they can actually listen. I think those are the important things.
So, Cliff, looking at a couple more questions before we just come into land. One would be really around you are seeing multiple trainees in different healthcare systems, different ecosystems, actually, under these high fidelity situations. I wondered if I could just get you to speak to some of the common errors you see from trainees when you improve the fidelity, you increase the pressure. What are some of the sort of commonalities of not necessarily failure, but of errors that you see in practice, or indeed in education, that seem to be almost a common theme?
I don't see a lot of errors really in the system that we train them in, because we set them up for success from the start. In less experienced trainees in other settings, if I see someone running a sim where they expect a surgical airway, I guess some of the common situations in that context would be a delay to doing the inevitable, persisting with other techniques, trying to talk themselves out of it. They can't be wanting me to do a surgical airway. Maybe I need to do something else with the laryngoscope, and trying to talk themselves out of it, trying to wish it away, and that just might reflect confidence as much as competence, and not wanting to fail at a procedure that they may have not had a chance to practice much in the training setting. So I think it's on us as trainers to set our teams up for success. So if I were to put my emergency medicine trainees in the ED through a simulation that required a surgical airway, I would definitely make sure they're already orientated to where that equipment is, how to use it. They've had a chance to practice it on a part task trainer first before we go anywhere near it in a sim. Otherwise, it's just not fair.
Yeah, indeed. No, indeed, absolutely. Setting people up for success in training, as indeed in practice, and almost like say improving that level of confidence. Just as we come into land, just one or two more questions. One would be from a feedback perspective on the courses, Cliff. How do you deliver feedback? Is it sort of looking at the successes and then the challenges, or how do you sort of give feedback to trainees? Is it just purely centered around the outcomes, or is there a success challenge kind of model you use, or how do you deliver feedback?
Well, during our HEMS induction, we concentrate on team training. So right at the beginning, everybody is told, whether they're doctor or paramedic or flight nurse, that they don't have to prove themselves. The fact that they managed to get a job in our system, the fact that we're employing them, means they're excellent. Otherwise, they wouldn't be working for us. So they don't have to prove that they are individually excellent. What they have to do throughout the course and show at the testing at the end of the course is the team output, because an individual patient doesn't care how good Cliff Reid is or paramedic Libby Hanrahan is. He cares about what Cliff and Libby are going to do as a team to that patient on any given day. So if one person on the team's having an off day, the other person's got to step up their game to maintain that team output. So you're supporting your colleague all the time and working as a team. So the sum, the whole is greater than the sum of the parts, as it were. And so when we're giving feedback, there is individual feedback if someone's struggling, but generally it's team feedback. And after simulations, there's a debriefing process. The debriefing is slightly longer in duration than the actual simulation itself. And we use the advocacy inquiry method, asking curious questions and trying to understand the frames through which people are thinking, but guiding the conversation towards the outcomes we want to see. That's in simulation. But of course, there's skills training, our pig lab, where feedback there is more coaching, standing next to the individual, guiding them on their, maybe the way they hold their scalpel, for example, and the way they cut, all the way through to tissue handling and procedural steps. And then they'll have an individual mentor that can give them individual feedback about, and again, asking them how they think they're going, and then guiding them about what we'd like to see more of, what we'd like to see less of, that we think will help them thrive more in our service.
So, Cliff, just as we're coming to land, just is there any take-home messages you could leave listeners with? There's been plenty of actual pearls throughout the actual interview, and I think something I'm taking certainly from this conversation is, like you said, it's almost that the biggest blocker is that decision in the first place, and overcoming that decision in your mind from a can't intubate, can't ventilate, and just moving through quickly so that you can start to facilitate your best chance at success. But could you maybe speak to just a few take-home messages for listeners?
Yeah, sure. I've got a couple. The first one, which I think I got from Scott Weingart, which is when you're preparing for this and you're considering the indications and when you'll do it, it's not if, it's when. So just use the phrase, when I come across a can't intubate, can't oxygenate situation, I will do a surgical airway. Not if I come across it, when. So that it's already happened in your mind. The decision lies in the past when you come to do the procedure, because the cognitive aspects are harder to overcome than the physical aspects. Most of the halo procedures are technically not challenging. So yeah, it's not if, it's when. And then just don't use the term failed airway. Failure shouldn't be in our vocabulary for our patients. It's an alternative airway. So, for patient, if you turn up with a patient to hospital and they've got a tube sticking out of their neck, but they're alive, don't use the word failed. We didn't have a failed airway. We had an unsuccessful laryngoscopy. So we've done an alternative airway through the front of neck, and we've maintained good saturations and normal end-tidal CO2. So it's an alternative airway. It's not a failed airway. You go through the nose, the mouth, or the neck. They're all fine. It's all cool. And that's a resuscitationist mindset. If you are an operating theatre-based anaesthetist and someone comes in for very minor elective cosmetic surgery and you're unable to control the airway without a front of neck access, if they've if they go home with a scar in the front of the neck, the system has at some level failed them. They haven't had a failed airway, but there is a failure of sorts, certainly in the mind of the anaesthetist. That's why they would be very hesitant to cut the neck in someone who's coming in for a cosmetic procedure, and then you make them cosmetically worse with a scar in the neck. That's awful. And so that I think there are much greater hurdles cognitively to overcome in that elective setting. But for pre-hospital practitioners and emergency physicians, critical care people, I think the word failure doesn't have to enter our vocabulary. If we've made a hole in the front of someone's neck, it's because they needed it. And we didn't put them in any kind of situation that required it. We were resuscitating them. And I think that's just a really important mindset. And again, will help us overcome that cognitive hurdle. If we're seeing it as an alternative airway rather than a failed airway, we'll just make a hole in the neck. It's all good.
Cliff, listen, thank you for the past 45 minutes. I think what we'll do in the show notes, we'll put links to the salad technique and indeed some of the teaching materials you've spoken to. But I just want to thank you for the past 45 minutes. It's been fantastic to get your insights. So thank you.
Thanks for having me, and keep up the great work, mate.